Hi guys, welcome to my channel and learning together. I hope all are doing fine. So I hope you have seen my previous two videos about heparin and LMWH. So today we will be seeing another medicine, that is warfarin, which is the last one. So before moving to the topic, if you like this video, please like, subscribe and hit the bell icon for quick notifications. So let's begin. So coming to warfarin, as you can see in the current slide, warfarin, different doses it comes. In this picture, you can see it is of 5 mg. Okay, so let's begin. So warfarin, it is a oral anticoagulant agent. So in my previous video of heparin, I have discussed about one a tree, anticoagulation tree I have shown you, in which warfarin came under the indirect anticoagulation. Okay, so it indirectly inhibits the coagulation factors. Okay, like heparin and LMWH, they are also in its action is indirect on the coagulation factors. So warfarin also has indirect action on the coagulation factor, but it has to be taken orally. Those were taken parenterally. Okay. So it is a anticoagulant agent which is used to prevent blood clots, and it comes in the brand name of Coumadin, and it is a blood thinner, as in layman term you can tell, and it inhibits coagulation. Okay, it prevents blood clots in the circulatory system. It comes in various brand names. Coumadin is the popular brand name. Then these are the coumarin derivatives like bis hydroxycoumarin, warfarin, acetylcoumarol. So this is the T half. You can see the T half of warfarin and all these are very high. There is 36 to 48 hours. Duration of action is also high. Okay, and dose of loading dose and maintenance dose, and these are the adverse side effects. So you can see frequent GIT disturbances for warfarin, sodium warfarin, that is alopecia, dermatitis, diarrhea. Acetylcoumarol, oral ulceration, GIT disturbances, dermatitis, and this ethyl biscomacetate, alopecia. So when you are giving these medicines to patients, you have to monitor the INR, okay, the prothrombin time, and to be taken in single dose at the same hour, usually bedtime each day. Okay. So as per the advice of the doctor, it has to be taken. Next, coming to the mechanism of action, as I have told you, it causes indirect. It has indirect action on the clotting factors. So in this picture, you can see that for activation of the clotting factors, gamma glutarate carboxylase, that is gamma carboxylation, is needed for this transformation. So for this activity, vitamin K is also needed. Okay, vitamin K gets converted into vitamin KO with the help of gamma glutamyl carboxylase. So KO gets converted into KH2 with the help of vitamin K oxide reductase. So when does this warfarin do? So warfarin has two enantiomers. One is S warfarin, another one is R warfarin. Okay, so this two inhibits this um, enzyme, vitamin K oxide reductase, which does not allow the conversion of this oxygen, and gets means hydrolysis of that of vitamin K does not take place. And if this is not formed, then gamma glutamyl carboxylase will also not be able to act. So activation of clotting factors will not take place. So this is the whole mechanism of action, that is warfarin inhibits this vitamin K oxide reductase. So as we know that clotting factors are vitamin K dependent. So inactive clotting factors get converted into active clotting factors in the presence of vitamin K and gamma carboxylation, but that does not happen because warfarin inhibits it. Coming to the indications, so it helps in the treatment and prophylaxis of venous thrombosis. Usually it is not given. We go for heparin or LMWH. In cases of pulmonary embolism also it can be ordered. Then for thromboembolic complication, yes. For atrial fibrillation and cardiac valve replacement, warfarin is given. But nowadays, we don't give, means warfarin is not mostly preferred. We go for DOACs, that is directly acting oral anticoagulant agents, because it has a specific action on a particular factor, means direct action on the coagulation factor. So its side effects are less as compared to that of warfarin. What does warfarin do? It inhibits multiple coagulation factor by its indirect action. But this DOACs, what they do, they means only specifically inhibit a particular factor. So therefore, the coagulation effect means is also there, as well as the side effects are also less. Less bleeding chances are there, and also we don't need any lab monitoring very frequently. Then reduction in the risk of death, recurrent myocardial infarction, thromboembolic events like stroke, systemic embolization after myocardial infarction. Also, in those cases also it is given. Coming to its pharmacokinetics, it is given orally as I have told you. Its drug composition, as I have told you, there is R and S enantiomer. So this S enantiomer is more potent than the R enantiomer. This is about all the chemistry about the drug. Okay, you remember or may not remember, it is not much important. Absorption, rapid and complete absorption is there, therefore it is given orally. Onset of action, this is important, that onset of action, it takes around 24 to 72 hours. As obviously as we are giving it orally, so it will take time for its action. And the peak effect is reached on 5 to 7 days after initiation. However, the patient's INR may increase in 36 to 72 hours after initiating the treatment. So whenever we tell a patient for any surgical procedures are um, advised, we tell the patients if the patient is on any anticoagulants, it should be stopped much before uh, much before from the day of surgery, because if the patient is on warfarin, then it can take time, because its duration of action, you see, it is around 5 to 7 days. So you have to tell the patient to stop the medicine beforehand, so that its effect does not be there on the surgery. Then duration of action is 2 to 5 days. Distribution is small volume of distribution is there, and protein binding is around 99%. Therefore, its duration of action is more, because protein binding is more. Then metabolism by various liver enzymes, it gets metabolized. Elimination half-life is around 20 to 60 hours. Mean is around 40, and it can be variable based upon the individual. Then time of peak approximately 4 hours. The 4 hours means it peak level occurs in the plasma, means in the blood. Excretion, it gets excreted through urine, that is 92% via urine it gets excreted. Adverse effects, significant hemorrhage can be there, like a GI hemorrhage, intracranial hemorrhage, hemarthrosis, intraocular bleeding. Then purple toe syndrome, warfarin induced necrosis. These are some of the side effects that can occur. Calciphylaxis, that is calcium depositions can be there in the skin. Osteoporosis, the nausea, vomiting, abdominal pain, bloating, flatulence, and an altered sense of taste. Okay, all these things can be there. So see, warfarin necrosis is there. Then this is purple toe syndrome. You can see the rashes on the toes. That occurs in first few weeks of starting warfarin. Okay. Then coming to the contraindications, so those who are hypersensitive to warfarin or having hemorrhagic tendencies, or any surgery is planned, or the patient has an abortion, eclampsia, preeclampsia, however high chances of bleeding is there. Then unsupervised patients with condition associated with high potential for non-adherence, sorry, spinal puncture and other diagnostic and therapeutic procedures, lumbar punctures, malignant hypertension, pregnancy. In pregnancy, it should not be given, but if the patient has mechanical heart valves and has a high risk of thromboembolism, it can be considered, or alternative agents can be given. You can say warfarin has teratogenic effects. So it has warfarin embryopathy syndrome. So fetal bone and cartilage formation abnormalities occur in the child. Facial abnormalities will be there. Okay. So the risk is highest when warfarin is administered during the 6th to 12th week. In the first trimester, if you are giving, then it has teratogenic effects. And the risks are dose dependent. A dose of less than 5 mg daily have the lowest risk. Okay, even if it is needed for the mother, as I've told you, if the mother has high chances of thromboembolism or any mechanical heart valve diseases there, then it can be given, but in low doses, or any alternative medicines should be prescribed. Then these are some of the factors. So I have divided into factors which enhance the effect of warfarin, factors which decrease the effect of warfarin. Factors which enhance the effect include debility, malnutrition, malabsorption, antibiotic supply of vitamin K to the liver is reduced in these conditions. Okay. So when vitamin K you are eating less, or the patient is malnourished, malabsorption, as I've told you, when protein binding is there, so its duration of action is longer, means uh, it takes time for its action. Whereas if you don't, if the person is malnourished, or some debility is there, means the protein content in the body will be low and the protein binding capacity of warfarin will be less. So more warfarin will be available for its action, and the coagulation, means in the anticoagulant effect will be more. Okay, like when it is bound to protein, the anticoagulation effect is slow. Whereas if it is not bound to the protein, so directly it will go and act, and the coagulation effect will be anticoagulation effect will be more. Then liver disease, chronic alcoholism, synthesis of clotting factors may be deficient. Okay, and also same thing, if you are not eating properly, then clotting factor formation will also not be there, and the enhancement of its effects might happen. Hyperthyroidism, as hyperthyroidism has a high metabolic state, so the clotting factors get degraded faster. The newborns have also low levels of vitamin K, so clotting factors are also less. So, but we don't have to give warfarin in newborns, but for a study purpose, you can study that newborns also are vitamin K deficient and clotting factors are also not formed properly, so it should not be given. Factors decreasing effects such as pregnancy. Okay, plasma level of clotting factor is higher in pregnancy. Nephrotic syndrome, because proteins are lost in urine, so the effect will not be there properly. Genetic warfarin resistance, affinity. Sometimes some individuals are warfarin resistant, even if you give high doses, so it does not show any anticoagulant effect. So it should be seen accordingly. Then enhance anticoagulation, that is broad spectrum antibiotics, aspirin, long acting sulfonides, indomethacin, phenytoin, and probenecid. This all displace warfarin from the plasma protein binding, and it enhances the anticoagulation. Chloramphenicol, erythromycin, celecoxib, cimetidine, all this inhibit warfarin metabolism. Tolbutamide, liquid paraffin. Okay, all this enhance anticoagulation, whereas reduce anticoagulation include barbiturates and oral contraceptives, because it increases the blood levels of clotting factors. So coming to the recommended INR range for different indications, like prophylaxis for DVTs and for similar indication, that is 2 to 2.5. Treatment for DVTs and that is stroke and hip surgery patients, it has 2 to 3. Whereas recurrent thromboembolism, atrial disease and prosthetic valves, it is 3 to 3.5 considered. Coming to management of warfarin toxicity, so warfarin, if overdose is there, so it can cause bleeding, chances of bleeding. So always stop the warfarin therapy if you are seeing the INR is above 5. So there are high chances that bleeding can be there. So stop the warfarin therapy, then administer vitamin K orally if there are no signs of any bleeding. And you should see a reduction in the INR within 24 hours. But if bleeding is there and INR is not reducing, then you can consider vitamin K administration if necessary. And also administer PCC, fresh frozen plasma, and activated factor 7 is considered in case of significant bleedings. So these are the some of the ranges in which what intervention should be taken. Like less than 4.5, no bleeding is there, so monitoring daily and all. This is the normal one, supratherapeutic INR. Uh, then INR 4.5 to 10, no bleeding. Then omitting 1 to 2 doses, readjusting dose more than 10. So if there is a major bleeding, any elevated INR, you should give vitamin K1, 5 to 10 mg IV, and hold warfarin, and also give PCC and other blood products if needed. Life-threatening bleeding also, vitamin K 10 mg fresh frozen plasma should be given. So this is the difference between warfarin and heparin. So heparin can be given vivo or versus vitro, means it is produced inside a body, endogenous, and also exogenously we also give. Whereas warfarin is exogenous only. Origin, as I have told in heparin slide, that is produced from basophils and mast cells, means origin is from a living organism, whereas warfarin is from a plant. Okay, coumarin plant is there. Mechanism of action, it stimulates antithrombin 3, and which indirectly inhibits 2, 7, 9, and 10, whereas this inhibit vitamin Ko oxide reductase enzyme, which is there, which is helpful for gamma carboxylation, but it does not take place because of the inhibition, and therefore factor 2, 7, 9, 10, okay, all this gets inhibited, as well as there's anticoagulation factors which are there, CSZ, okay, this also gets inhibited. Site of action is blood, here it is liver. Onset is rapid, it is slow. Duration is short, whereas it is long. Administration is IV or sub-Q, here it is orally. Sometimes IM is mainly avoided because it can cause hematoma, and this is given per orally. Monitoring APTT, this is PT-INR because it affects the extrinsic coagulation pathway more, and this one has effect on intrinsic coagulation pathway. You can remember like HAPT. Okay, HAPT means heparin. For heparin you see APTT, and for warfarin West Indies means you see I, that is INR. Antidote is protamine sulfate. Here vitamin K is the antidote, and for fast action fresh frozen plasma prothrombin concentrates can be given. In prothrombin concentrate, that is 2, 7, 9, and 10 factors are present. Cross placenta, heparin does not cross placenta, whereas warfarin can crosses placenta and teratogenic effect. Teratogenic effect, heparin has no teratogenic effect, warfarin has. So this is the difference. I hope you understood the difference. So this is about the causes of prolonged PT and prolonged APTT. Prolonged PT and normal APTT. If you see, then these are the conditions, like warfarin if it is given, so PT will be deranged. It mainly measures the extrinsic pathway. Then normal PT, prolonged APTT means the intrinsic pathway is affected. So means heparin or direct factor 10A inhibitors can inhibit the those factors and can cause prolonged APTT. And if prolonged PT and APTT is there, means some liver disease or this factor, which are common factors like factor 5, factor 10, deficiency of prothrombin or fibrinogen factor. So these are involved in the common pathway coagulation cascade. So it can cause both, prolongation of both. Severe vitamin K deficiency. Supratherapeutic doses of anticoagulants like heparin or warfarin, if you are giving in overdose, then also it can cause both prolongation of PT and APTT. So these are the nursing responsibilities. Always check the PT, INR of the patients who are on anticoagulants, and also check for any signs of bleeding like dark tarry stools, nosebleeds, hematomas. Okay, and and also check the hemoglobin and hematocrit level before initiating all this warfarin therapies every 6 months, because it has chances of bleeding and hemoglobin can get low. And this is a very important part, that food recommendations while the patient is on warfarin. So green tea leaves, Brussels sprouts, leafy green vegetables, all this have um, peas and green beans have less vitamin K. So all these foods which are high in vitamin K agents, so it can have a decreased effectiveness of the warfarin. So you should counsel the patients about all these foods, not to take all these foods in excess quantity. Peas and green beans can be taken because it has less vitamin K. And cranberry juice, grapefruit juice should not be taken because it increases the chances of bleeding, because it inhibits the liver enzymes, and the metabolism of warfarin does not take place, and it is availability becomes more in the body. Then oral anticoagulants, this action gets enhanced in patients who have any liver disease, hepatitis, cirrhosis. So INR should be closely monitored. And all this close monitoring of patients' INR in renal impairment is a recommended procedure, because as I've told, warfarin and or heparin gets excreted out through the kidneys. Maximum part gets excreted out through the kidneys. So it is also important to note that warfarin is not dialyzable through hemodialysis. Okay, it can't be removed because it is protein bound, and protein can't pass through the dialysate membrane. So therefore, you should check the INR levels of both liver disease patients as well as the renal impairment patients. Anticoagulant effect also interact with papaya, ginger, fenugreek, clove oil, asafoetida, capsaicin, which is present in chili. So it should also be told to patients that not to take in excessive quantities. Okay, so these are the food recommendations that should be counseled by the nurses to the patients. So thank you. So this was the end of this series about we learned about heparin, LMWH, and warfarin. I hope you liked all the three videos. And if you have any suggestions, any doubts, please feel free to ask in the comment section. So I will be happy to answer it. So, okay, bye. See you in my next video. So have a good day. Thank you.